Welcome to the video tutorial on the abstract 1984 of plea clinical trial. So previously we have seen the video tutorial of abstract 1974 where we have seen the study protocol of the plea clinical trial. Apart from that, we have seen different terms like end of treatment, test of cure, baseline MICs, etc. So this tutorial focuses on the abstract number 1984 of plea clinical trial. So as we know, the objective of plea clinical trial was to prove that Elores is non-inferior to meropenem in treating ESBL positive infections for patients of complicated UTI including acute pyelonephritis. And the objective of this abstract 1984 was to assess the changes in MIC values and the genotypic profile of the involved pathogens in those patients who had treatment failure with either of the drug. So for those patients who failed either the Elores therapy or the meropenem therapy, the MIC values and changes in the MIC values and genotypic profile of the pathogens involved were analyzed in this study. So this is the detail of all the patients who failed either Elores therapy or either meropenem therapy. So we can see here that 3 patients were from Elores group and 7 from the meropenem group. And also we can see different terms here like baseline values, test of cure. So baseline, we know that value of MICs and genotypic profile, etc., which were taken from the initial sample when the patients were enrolled in the study. And TOC is test of cure, that is the period of 10 plus minus 4 days, that is 6 to 14 days after end of treatment. So at baseline, the MIC values of Elores and meropenem were analyzed. Apart from that, the gene profiles and the susceptible drugs were analyzed. Similarly, at TOC, the MIC values of Elores and meropenem, the gene profile of the pathogens involved, susceptible drugs, and as we know at TOC, the clinical cure and microbiological eradication was also analyzed. So a total of 10 patients failed either Elores or meropenem therapy. 3 were in Elores group and 7 were in meropenem group. So out of these 10 patients, 9 patients had complicated UTI, and on an average 8 days of IV therapy was given to these patients. And there was just an exception, one patient who reported a super infection at test of cure visit. So what is super infection? So super infection means an infection from another pathogen during the treatment. So for example, if a patient was infected with Klebsiella pneumoniae, so during the treatment or at TOC, if he was infected with a different pathogen, for example E. coli, so this kind of infection is known as super infection. So in this study also, one patient was reported to have a super infection at test of cure visit. So of the 10 patients, 10 failed patients, 10 patients who failed the therapy either with Elores or meropenem, 9 out of these 10 patients had complicated UTI. Average 8 days of IV therapy was given to these patients, and one patient has reported super infection at the TOC visit. So this was the one patient who reported super infection at the TOC. So here we can see at baseline the pathogen was Klebsiella pneumoniae, but at TOC the pathogen identified was Escherichia coli or E. coli. So this is from a different pathogen. Infection is now from a different pathogen, so it is now a super infection. And out of these 10 patients, 3 patients were clinically cured but reported microbiological failure at TOC visit. So these are these 3 patients who were clinically cured at TOC but still showing microbiological eradication was not there. And 2 of these patients were in meropenem group and 1 was in Elores group. So these patients were categorized as asymptomatic bacteriuria, which means they were asymptomatic but bacteria was present in urine, but because they were asymptomatic, this presence of bacteria in urine is not considered as an infection, and therefore no further antibiotic therapy was administered. And even these patients reported microbiological eradication at the follow-up visit. So what is this follow-up visit? Follow-up visit is the period of 7 plus minus 2 days, which means 5 to 9 days after the TOC, test of visit. So out of these 10 patients, 3 patients reported clinical cure but microbiological failure at the TOC. 2 of these patients were in meropenem group, 1 was in Elores group, and these 3 patients were considered as or categorized as asymptomatic bacteriuria and no antibiotic therapy was administered. And even at follow visit, that is TOC plus 7 plus minus 2 days. So at follow visit, these patients reported microbiological eradication also. Now again, an important outcome of this abstract or this study was that 2 patients, they reported a 4-fold and even more than 4-fold increase in the baseline MIC values. So one patient was of complicated UTI and another was of acute pyelonephritis. Both failed the meropenem therapy and they have reported 4-fold and even more than 4-fold increase in the MIC values than the baseline levels. So if we talk about the patient who was of the acute pyelonephritis, the MIC value of Elores was 2 microgram per ml initially at the baseline, but at TOC the MIC levels of Elores they were reported to be at more than 32 microgram per ml. Similarly, the baseline levels or the baseline MICs MIC of meropenem was 1 microgram per ml, but at TOC it was reported to be at 16 microgram per ml. So there is 4-fold or more than 4-fold increase in the baseline MIC values at TOC for both of the drugs. Similarly, for the patient of complicated UTI, the MIC value of Elores was 1 microgram per ml and at TOC it was more than 32 microgram per ml. Similarly, for meropenem, it was 1 microgram per ml at the baseline, but at TOC it was observed at 8 microgram per ml. So both of these patients who failed the meropenem therapy, 4-fold or more than 4-fold increase in the baseline MIC levels were analyzed or reported for both of the study drugs, even Elores and meropenem also. Also, the genetic profile or gene profile of these patients who failed the meropenem therapy, it was also changed. So this is again an important outcome of this abstract 1984 of plea clinical trial, that the failed treatment outcomes with meropenem were associated with genetic variation like acquisition of resistant carbapinamase genes. So here we can see the patient who failed the meropenem therapy and who was infected with acute pyelonephritis. Initially at baseline, the gene profile, it includes TEM, SHV, MC and CTXM, but at TOC, OXA and KPC. KPC is Klebsiella pneumoniae carbapinamase, which is a carbapinamase enzyme. Similarly, few variants of OXA like OXA48, it is also carbapinamase. So at TOC, these OXA and KPC enzymes are also produced by these pathogens who failed the meropenem therapy. Similarly, for the patient of complicated UTI, at baseline the gene profile was TEM, SHV, MC and CTXM, and similarly at TOC, OXA and KPC genes were also observed in the pathogens who failed the meropenem therapy. And also their MICs were increased 4-fold and even more than 4-folds for both the drugs, Elores and meropenem. So we can conclude that the failed treatment outcomes with meropenem were associated with genetic variations like acquisition of carbapinamase genes. And post-treatment MICs in such patients showed a 4-fold or more than 4-fold increase in the study drugs and reduced susceptibility even to the comparator drugs like Elores. Also, none of the patients treated with Elores reported any significant increase in the post-treatment MIC or acquisition of resistant genes. So this is again an important outcome which we can share with our doctors, that patients who failed Elores therapy, none of the patient had reported a significant increase in the MIC at TOC or post-treatment, and even none of the resistant genes were acquired in these kind of patients. So these are the 3 patients who failed Elores therapy we can see none of the patient shown a significant increase in MIC levels than baseline levels at TOC. Just a single patient who showed increase in MIC levels, but still that was a super infection, which means that the patient was now infected with another pathogen. So this is a super infection, and for rest of the two patients who failed Elores therapy, MIC levels had not increased significantly. So finally, we can conclude that these results highlight the importance of effective empirical therapy, as inadequate treatments and or dosages can lead to the selection of resistant mutant genes and can severely hamper the effectiveness of other drugs also that may have been proven otherwise effective. So in this study, we have seen that the patients who failed meropenem therapy, the MIC levels has also increased even for Elores also. So if initially Elores was given to these patients, there are chances that they will have a good clinical cure and microbiological eradication. And even if there is a treatment failure at TOC, it should not have increased the MIC level for other drugs. So it highlights the importance of early initiation of appropriate antibiotic therapy at the right dose. So we can say, in other words, just a right empirical antibiotic with right dose and at right time can make all the difference. So thank you, friends.